Sure.
Okay, so you take, you can have both of them. Is this turned on?
This just needs to.
Yeah, okay. Okay, good.
All right, so the case is about a 60-year-old female patient. This is the vignette. So decreased distance vision. She had an abnormal visual field. The patient was seen by a neuro-op, had a brain MRI and carotid ultrasound, which were normal. Then the patient was seen by a retina doctor in Tampa and was sent here. The patient had a migraine aura in January 2021. Medical history is significant for rheumatoid arthritis. She's on various medications, including Plaquenil 400 milligrams per day for 15 years. She did stop 3 months ago. There's also methotrexate, 10 milligrams, glucagon, 5 milligrams, estratab, folic acid, imodidine, vitamin D3, omega-3, Celebrex, 200 milligram oral capsule. So her vision in the right eye, without correction is 20/40, no pinhole improvement, and near of J3. Vision in the left eye is 20/20, near of J2. Intraocular pressure by 2010 at 1311, and her weight is 140 pounds.
Okay, so this is a color fundus photo of the right eye, kind of zoomed in on the macula. The media looks clear. The nerve looks pink and sharp with a normal cup to disc. The vessels, they look okay. Macula looks pretty normal to me. Color fundus photo of the left eye. Media looks clear. The nerve looks pink and sharp, cup to disc, maybe a little bit bigger. I would say it's like a 0.5, 0.4. Vessels look good. The macula, maybe there's like one single drusen right near the fovea, but I'd really be reaching. That's all I got. Oh, actually, there was a flame hemorrhage before. I just noticed that.
Take it back. There's no going back.
You can see it there.
You can
give him
Yeah.
the keyboard. But you give him that.
Yeah, there's a flame hemorrhage along the inferior arcade.
Oh, very nice. Yeah. Yeah, right. Let's see. You can see it on the autofluorescence ocean. Right there.
Yeah.
Okay, these are fundus autofluorescence of the right and left eye. There's on the right eye, there's a small area of hypoautofluorescence along the inferior arcade, possibly consistent with another flame hemorrhage. Fovea, it looks a little bit hypoautofluorescent in the center. Yeah, it looks okay. The left eye, there's another flame hemorrhage inferiorly along the inferior arcade. There's a small area of hypoautofluorescence along the superior fovea, and then another area, I would say, in the temporal fovea.
Nice. Yeah, what do you think about kind of like the parafoveal? Is there patterns you notice? You're correct, everything you mentioned. I'll say kind of don't focus on that little hemorrhage.
Um,
And you can go back to these if you want to.
Is there any hyperautofluorescence anywhere, would you say?
yeah, actually, an area of hyperautofluorescence if you go a little bit further out. Like the peripheral macula, I guess.
Yeah, I would agree. It's kind of parafoveally, kind of like a circular rim.
You can see your arrow if you point.
Okay.
Yeah, I see
here,
both
right?
sides.
You can see that to here and perhaps coming from around here as well. And yeah, the hypoautofluorescent center here for the fovea, that's kind of the normal expected pattern. And that's, yeah, keep going.
So this is a OCT of the right eye. The vitreous looks clear. It looks like it's still attached. Attention is drawn to the outer retina. It looks like there's disruption of the ILM in the parafoveal, possibly consistent with a flying saucer sign. And then
You mean external, ELM.
oh yes, ELM, sorry.
So where do you see the loss of the ELM?
Parafoveally,
Both sides of the fovea?
both sides.
Good, okay. And then you're alluding to flying saucer sign, which suggests, more subfoveally, normal inner and outer retinal anatomy. Sounds very good.
Where's the flying saucer? The little thing in the, I don't use that word.
Black space in the middle.
Like UFO, like trapezoidal sort of here.
That thing, okay.
Yeah, and then, the loss of the layer there accentuates that.
Right.
Okay, so this is an OCT of the left eye. The vitreous looks clear. It looks like we have the start of a posterior vitreous detachment temporally, but it looks like it's still attached at the fovea. The inner retinal anatomy looks normal, and then moving to the outer retina, same as the other OCT. Looks like there's a disruption of the ELM, excuse me, and the ellipsoid zone in parafoveally.
Good. All right, now we're going 1 year later.
Okay, so fundus autofluorescence of both eyes a year later. It looks like there's a little bit more hyperautoflourescence in like a ring in the peripheral macula in both eyes compared to before.
Fluorescence bilaterally, parafoveally, and then everything else is pretty similar then.
Yep.
This is
Yeah.
Oh, here you go. Yeah. Oh, it's for your case. Yeah.
So this is an OCT of the right eye again. The vitreous looks clear. It looks like it's starting to attach a little bit more compared to before. Temporally in this eye, looks like there's a little bit more disruption of the ellipsoid zone and the ELM, maybe a little bit more in this eye compared to a year ago. Okay, OCT of the left eye. There's further detachment of the posterior vitreous, but it's still attached at the fovea. Moving to the outer retina, maybe a little bit more thinning parafoveally compared to before, kind of consistent.
All right, so I'll just recap some of the findings. The fundus photos were overall pretty unremarkable. At least on my computer, actually looking at the bigger screen, I feel like you maybe can see some pigmentary changes, but we can go back to that. The autofluorescence did show a ring of hyperautoflourescence, parafoveally OU, as you astutely pointed out. And the OCT showed paracentral ellipsoid zone loss with the fovea maintained bilaterally.
Hey.
We're studying differential.
High on my differential is plaquenil toxicity. I'll also include retinitis pigmentosa, retinal dystrophy, Best disease, I guess, maybe.
Yeah, I mean, obviously pointing the case points quite significantly towards hydroxychloroquine toxicity, but if we run some other possible dystrophies, like you mentioned, cone dystrophy, Stargardt's, maybe ACE or AIM, things that, and maybe can affect the macula like that. But really, the pattern is more consistent. So the history with hydroxychloroquine toxicity, so that is the correct diagnosis. And so I'm just going to talk a little bit about, that's really hydroxychloroquine is abbreviated HCQ, a brand name Plaquenil. It's originally derived from quinine, which is an antimalarial. As we know, it's most commonly used for rheumatoid arthritis and lupus, and it's been very commonly prescribed since the 1950s. With other than the eye effects, pretty minimal side effect profile, so well liked in primary care rheumatology clinics. And it's also used to treat and prevent malaria. Your typical dose is going to be 200 to 400 milligrams daily for RA or lupus. And of course, it's not effective.
Are you sure?
It's no progressive. One can say it's no ivermectin.
And there were large randomly controlled trials showing this, and there are side effects to use in the general population, including prolonged QT syndrome and cardiac arrhythmia. So it's not totally harmless to give to people when it's not effective for this entity.
What is the mechanism of action in rheumatoid arthritis and SLE? How does it work? Does anyone know how it works?
It's known. I don't remember.
Yeah.
It used to not be known. It used to be one of these, but now it's known, but I don't remember what it is.
I don't know what it
I think
is.
it has to do with destroying the lysosomes of
Well, that sounds-
white blood cells. Yeah, I should know that. A couple months ago, I was reading about this more with the presentation, but I think that's what it was. Affecting the white blood cell performance, and so less autoimmune response that way. I think T cells specifically. If you thought malaria was just a problem overseas, think again. So there's 2 years ago, there were actually 4 cases in Dr. Harvey's backyard in Sarasota. And they were all treated.
That's where I'm from.
Oh,
Yeah, just,
yeah.
yeah.
They were all treated, but yeah, wear bug spray out there. Let's focus in on the hydroxychloroquine retinopathy entity that we mentioned for the case. So here is the mechanism for how it affects the retina. Hydroxychloroquine strongly binds melanin in the RPE, interfering with lysosomal function. This leads to lipofuscin buildup and subsequent RPE damage. And then in more end stage, it will affect the cornea capillaris and the retina RPE. The recommendations by the AAO, and we should know these numbers. The maximum dose is less than 5 milligrams per kilogram per day using the real body weight. The risk does increase after 5 years or a cumulative dose of greater than 1,000 grams. And so Dr. Cohen asked me to crunch the numbers for our patient, which is why we had all that data, the weight and so forth. So she was a 63 kilogram woman, which is about 140 pounds. And at a dosage maximum of 5 milligrams per kg per day, she should be getting 315 milligrams per day max. If you recall, she's getting 400 milligrams a day for 15 years straight. So that put her at a daily dose that was too high based on that recommendation, and a cumulative dose that's twice as high.
So that was this by a rheumatologist and what?
Yeah, people are calculating more than they used to. Like, this is sort of slowly working its way. It's interesting. I saw a note from Chris Girini, an optometrist that we work with, and it was all calculated out.
Yeah,
Yeah, it was all calculated in
He's
the charts,
exceptional.
almost automatically.
he's really good though.
Yeah, I was like, whoa.
Like that.
So every patient, I sit there and pull out my phone and I calculate it for
Do you do it on lean body weight or their actual body
them.
weight?
Actual body weight.
Actual body
Supposed to be
weight.
actual.
Like a warning message.
Right.
Yeah. Like
Okay.
I think it would now.
Hmm.
Because,
Well, right, that recommendation is from just 3 years ago.
yeah,
We've
like
gone for much
recently,
longer.
like
Yeah.
now this is the.
There's some important additional risk factors that we have seen tested here for OCAPs and whatnot. If you have concurrent tamoxifen use, that increases your risk of hydroxychloroquine retinopathy by a factor of 5 to 10x. If you have other retinal disease, that should make sense. And then also if you have renal insufficiency, as it's metabolized by the kidney partially, so you have higher doses, it's not being metabolized appropriately. At recommended doses, the risk of toxicity up to 5 years is under 1%, and up to 10 years, it's under 2%, but then it starts to rise more sharply. It's nearly 20% after 20 years.
Whoa. Whoa.
Symptoms and screening guidelines. So the baseline, it's recommended to have a baseline fundus exam within 1 year of starting the medication. Then you don't see the patient for 5 years, so no further testing. And then we do want to start doing yearly exams after 5 years with OCT and visual fields is the recommendation. Now, it's important to note that patients are mostly going to be asymptomatic with this entity, especially earlier on. But if they do have symptoms, they might include paracentral scotomas, central scotomas, color vision changes. They can even reports of flashing lights, topsias, central loss of contrast, or difficulty reading despite having excellent Snellen acuity. Again, another important point of this case here, the fundus exam and color photos are both unreliable early on. But then later in the process, you'll see some funduscopic exam changes. So subtle paracentral depigmentation of the RPE which does spare the central fovea. And this, of course, gives us our classic bullseye maculopathy. So that's really more in the severe, moderate to severe phase of the disease. You can see some of the pattern there as well. After 10 years, after 15 years, pretty pronounced bullseye on that last one there. But it's not the only entity they call the bullseye. You can see this associated with cone dystrophies, again, acute intermittent maculopathy, other macular dystrophies. That's why I threw those on the differential. And then let's focus on the fundus autofluorescence findings here. So as Sarah noted, that we had some hyperautofluorescence around the parafoveal and extramacular region. And this is where the RPE is dying due to the increased lipofuscin from the hydroxychloroquine. Later on, though, we get a similar
hyperfluorescence. The hyperfluorescence.
Yes,
Okay.
hyperautofluorescence. Yeah.
I think it's more the outer retina is you're losing the chromophores in the outer retina to give you the hyperfluorescence.
Yeah.
It's a little tricky. So because the RP, I don't know, it could be either. It could be sick RP. It could also be scarlet window defect.
And then we have late bullseye patterns sort of here again with the hyperautofluorescence paracentrally. So that's when it starts to actually get darker there. Hypofluorescence.
So what makes it bright in this is not lipofuscin accumulation like an open bowl.
I think it's a window defect. Did they say it's lipofuscin?
That's why, yeah, that's why it's red.
Okay.
It's
Well, that might be
dying, and
right.
then when it fully dies, it gets darker there.
Because it typically I used to think that with hyperautofluorescence, but the more you look at it, if you see an OCT where your outer retina is shot, that means you've lost your photoreceptors, and your photoreceptors are darker, so you get a window defect there. So I think it's more of a window defect without a retinal atrophy. So you're seeing more than you should be. I think if you were to peel the retina off of those patients, like that case I showed in the introductory lecture, I got peeled the macula. If you were to peel the macula off a patient with plaque toxicity, you would probably get even. I think everything would be fluorescing evenly. And then if you put it back, you would see that there's the bullseye because you're seeing through it more. 90% sure that's right. Not 100.
I have to write a letter to the editor of the BCSC. So I'm
Yeah.
sure I got that.
Well, because lipofuscin accumulation also makes you hyperautofluorescent, but that's putting something there, and this is more like taking something away. When you have plaque toxicity, but that's what they say.
But you do it to be, yeah, it's
You
kind
do
of
it,
the Bible.
yeah.
It's canonized.
All right, the OCT findings again here. So we have disruption of the ellipsoid zone in the parafoveal or pericentral retina. If you see this, it's already time to stop the hydroxychloroquine. And then again, the later sign that we've been hearing a lot about is this flying saucer sign. That's when you more clearly have the central subfoveal area spared, but then surrounding it, the parafoveal ellipsoid zone loss. And then eventually you can lose more of the inner layers.
There's a guy named Robin Vora who gives a really good talk on plaque toxicity, and he talks about OCT thickness maps as being a very early sign.
I think there's something where the computers, no, I haven't seen it, but I reviewed a paper once for publication. I think the computers will be better than us at this probably within a couple of years.
Yeah.
And then it'll be a decision like, when do you stop? But I think they're gonna be able to find it quicker than we will.
It's because the volume changes before because you see it, the flying saucers, because the juxtafoveal retinal thickness has decreased, the foveal thickness has not decreased. So you can pick that up pretty early as you get even earlier changes. He says that picks it up earlier than any other testing modalities. They're really good.
Like your figure
publication
C on that really is, any little anything there, you should be like, okay, this black one.
The problem I had is that they were often in patients with early AMD or moderate AMD, and then you throw up your hands because it's the AMD, is it the plaquenil, and
hard to tell, yeah.
I usually just said, take the plaquenil. You're gonna go blind anyway.
I'm sure. Go ahead, Mathias.
All right. Moving here. Then just for the findings on the Humphreys multifocal ERG. So in early cases, you'll typically have a paracentral scotoma, most sensitive to the 10-2 visual field. And then sort of classically, Asian folks tend to have more peripheral macular damage and therefore a, wider field, 24-2 or 30-2, companies would pick that up more likely. And multifocal ERG is actually a very sensitive test for this entity as well, but not very practical. And you would expect to see, again, this, paracentral depression of retinal responses, and that's correlating to areas of damage. So it is irreversible retinopathy once it occurs, which emphasizes the importance of early detection and early discontinuation of hydroxychloroquine, which then can prevent progression in most cases. Continued use can result in a range from mild to moderate to severe to end stage, which would include severe central vision loss, count fingers or worse. So it's important to collaborate with our rheum, derm, or primary care colleagues in the management of these patients, because we'll be able to see some of these, this issue develop and be able to guide the management in a way that they obviously cannot. Oh, what do you have here? Oh, it's Kevin's corner. So, hydroxychloroquine can also cause Retinopathy. So there's actually no relationship of this finding to the presence of hydroxychloroquine retinopathy, and it's usually asymptomatic, and the deposits do go away if the drug is discontinued.
I've never seen that. So where do you get the keratopathy?
Anterior stroma, I believe.
Anterior stroma.
Goes away.
What? It can cause a what?
Keratopathy.
Oh, exclamation point. I was
This
like,
is
what's
corneal
the
deposits.
why?
Can
Okay.
it cause verticillata as well?
I've never seen that.
I saw that.
Is that because you're going into cornea?
I guess so.
Yeah.
And I'm from Sarasota.
You only be the 48th refractive surgeon in Sarasota County when you go back there.
I might add some retina to my practice.
Gotta do that.
Make myself unique.
Yeah.
Yeah, you can get it.
All right, I think that covers it.
I'm telling you.
And there's.
Oh, very nice photo credits, yeah, beautifully done. So go back to your slide with the thing so we can discuss it.
Any other?
The, your autofluorescence is probably the best.
No proximity.
Yeah, the
Wait, that was it. We want the actual.
Oh, yeah, actually. So a couple things, if you're screening in Asians, a 10-2 won't pick it up soon enough. Because they get a different pattern, so I do a 24-2 and a 10-2 in Asians, and I do a 30 and a 55 autofluorescence. And we don't have the wide angle OCTs yet, but I have an Asian lady who did very, very poorly. Slightly before it was published that it was a totally different retinopathy. I wanted to, it's pretty much blind now from Plaquenil. And then with the macular generation, like Dr. Pavin said, I tend to not stop them. If it's typical macular generation and they got Plaquenil, I don't stop it.